All right, so without further ado, I get to talk about musculoskeletal imaging. And whenever I think of the musculoskeletal system, I think of sports. And some of my favorite times were spent at Fenway Park watching the ball players. So, in terms of disclosures, I have a couple. I am a consultant for In Vitro Konica Minolta, as well as the Center for Probe Development and Commercialization. Otherwise, I have no financial relationship with a commercial organization that may have a direct or indirect interest on the content of this presentation. In terms of an outline, I thought I would start off with some background, then some imaging pitfalls, talk about some specific uses of musculoskeletal imaging in terms of nuclear medicine, and then some future prospects. So without further ado, when we talk about skeletal scintigraphy, we're typically talking about technetium-labeled MDP. You can give either an empiric dose or a weight-based dose. I've seen both. Usually you will do flow phase over the region of interest for about 2 minutes, followed almost immediately by tissue phase images, which typically are another 2 minutes, and then skeletal phase images, which are acquired 3 to 4 hours later. Now, you can often get away with just doing your skeletal phase imaging, particularly if you're looking at metastases and doing a follow-up. However, if there's any chance that you're going to want to see whether you have increased blood flow and capillary permeability, as in infection or an osteoid osteoma for that matter, it can be very helpful to do 3-phase imaging. You can use pinhole or converging collimators, very helpful in pediatrics or for small parts. And SPECT is very helpful for both increasing contrast and localization. They say SPECT alone increases contrast about 20 times over planar images. So if you really need to see something, it can be very helpful. The other thing that I honestly have become more and more of a fan of, if you have access to it, is SPECT CT. So something to keep in mind is that the bone scan changes as you age, as do most things actually. So I'm showing you a 2-week-old boy by comparison with a 12-year-old boy, and finally a 54-year-old woman. The big thing to remember is that you see uptake in the physes and apophyses and absent uptake in non-ossified structures. And when you think about it, it makes logical sense because TEC-MDP is taken up by osteoblasts as they turn over and incorporated into the bone. So where the growth plate is where you actually have very brisk osteoblastic turnover. If you don't have any osteoblastic turnover, you don't see anything on a bone scan. And why is this so important? It's so important, perhaps more in the pediatric population, but the issue is that you can get physiologic hotspots, so to speak, on bone scans. And it's simply related to the normal ossification pattern of the bones. So don't get fooled. This is a common one. This is asymmetric focal uptake in the ischiopubic synchondrosis, which ossifies between 4 and 12 years of age. Again, if you happen to have a CAT scan, it can be very helpful for correlation purposes. Otherwise, keep in mind when you're looking at younger patients, the ossification pattern is truly key.